All right, good afternoon. So this is our session on the Rotary Healthy Communities Challenge, or RHCC for short, which is a bold step towards transforming community health and child health through community empowerment and Rotary leadership. The Rotary Healthy Communities Challenge is a $30 million program that's co-funded by the Gates Foundation, World Vision US, and Rotary. Rotary's contributed $10 million to this program, which is Rotary's single largest investment in any program outside of our work with polio. RHCC is a core part of Rotary's health strategy now, and our commitment to equity and sustainable systems and delivering health services when and where people need them. It's building on the successes of Partners for a Malaria-Free Zambia, which was our first Programs of Scale awardee. And it's a testament, and I always say, I've traveled to Zambia with Bill Feld and Jenny Andrews and Martha Lungu. The Partners for a Malaria-Free Zambia was a true testament to those involved, those Rotary members who've been really in charge for decades through their work with the Seattle clubs and the clubs in Zambia for some time. So kudos to them. We're standing on their shoulders. Now, our goal is clear within Rotary and within our global health strategy to increase Rotary's influence as a global health leader in strengthening these community health systems by implementing and scaling the Rotary Healthy Communities Challenge. So we've set up a structure where country committees are convening partners, they're building capacity for community health workers within their communities, and they're demonstrating that Rotary's power is not just as funders or fundraisers, but as decision makers and advocates in health. This work is particularly critical now. We've been hearing about the recent losses of U.S. government funding, USAID, the President's Malaria Initiative, and this has disrupted access to many malaria commodities, testing kits, treatment across several countries, including those that are involved in the RHCC program. So this gap really underscores the urgent and the needed investments in community health systems, especially those that are delivering the full integrated community case management package. So not only focusing on malaria, as many programs have been before, but also incorporating pneumonia and diarrheal services into that package as well. So today we'll hear from two of our country leaders, our Rotarian leaders who have joined me here today on stage that have been working on the ground in Nigeria and Zambia. We'll explore how the Rotary Healthy Communities Challenge theory of change is really coming to life through these Rotary-led country committees and how they're creating alignment with national health systems. And we'll talk about just how Rotarians all over the world can take action. So I'd like to introduce you to my panelists here today. We have Past District Governor Larry Mapani, who is the country committee lead in Zambia. And we also have Dr. Dele Balogun, who is the country committee lead in Nigeria. So these individuals here were nominated by their district governors and the full spectrum of district leadership within their countries. And in the case of Nigeria, nominated by 6 district governors and working together with district leadership, with Rotarians, with Rotaractors, with other NGOs, implementing partners to really develop country programs and oversee their implementation. So I'll go ahead and join them on stage, and we'll have a discussion about where we are with RHCC, how well the model has been working, how advocacy efforts are underway, and some of the key learnings and takeaways that we've seen thus far, with the caveat that RHCC is in its infancy. Many programs are just underway. We don't have joining us here today our leads for the Democratic Republic of Congo and Mozambique, who could not be with us here today, but we'll provide some of the overview for those programs in between. Thank you. All right. So we'll start off a little bit with some country introductions. So we'll start here with Pastor Governor Larry, can you describe the work of RHCC in Zambia and some of the priorities that Zambia has for the program?
Thank you very much, Nyreese, and good afternoon, everyone. As we heard, my name is Larry Mapani. I'm a member of the Rotary Club of Kitwe in Zambia, District 9210, and I'm also a member of the board of Malaria Partners Zambia. Coming to the RHCC, it's, as Nyreese said, it's in its infancy, but the committee which was constituted to take charge of the project, meaning design and implementation oversight, is RHCC Zambia, and it was constituted on the basis of being as inclusive as possible. We have basically all the stakeholders included in that committee. It's a committee of 17 people, so we have, obviously it's Rotary-led because that's the way it's designed. We have World Vision, our implementation partners, and MPZ. We got PATH, the Ministry of Health, and the National Malaria Elimination Council as well as the people from the community to ensure that everyone is on board from the start. The Zambian project, in a way, was very fortunate because we're riding on the success that was scored by the Program of Scale project that was driven by Partners for Malaria-Free Zambia, which was a wonderful success. And in coming up with implementing partners, it was very easy for us because we looked at a team that did such a wonderful job in the first part, which is the POS that was a forerunner. So we didn't change the team. As you know, like in football, you don't change a winning team. So it was very, very simple for us to just ride on that. And that's the experience that we have. As for the focus, yes, obviously we're looking at ensuring that the disease burden that is brought in by malaria, pneumonia, and diarrhea is reduced, especially in children under the age of 5. And we are obviously working very closely with the Ministry of Health. The areas that were chosen for implementation of this project were agreed upon and recommended by the Ministry of Health. That's how you find that there are 4 districts in the northern part of Zambia, which is Northern Province, and 2 districts in Central Province. All these were data-driven decisions that made us go into those areas.
Thank you so much. And Dr. Balogun, question to you. Can you describe the work of RHCC in Nigeria and some of the priorities?
Thank you very much, Dr. Nyreese Castro. Nigeria is unique in the sense that we have 6 different districts and we have a population of over 237 million people, and we have a land mass of about 991 square kilometers. And this is a new project. The project is just about 9 months old. And the first thing we did was to choose an implementing partner. So many organizations were recommended by Bill Gates, and they were interviewed, and we selected PATH. So PATH is our implementing partner. And this being a new project, and also PATH coming into Nigeria for this project, it was like a young marriage. And it took quite some time before we understood how to relate with ourselves. But the first major thing that we did, we met with the strategic partners, the Federal Ministry of Health, National Agency, Primary Health Care, Nigerian Malaria Eradication Committee, and we met with quite a number of other stakeholders, both international and within the country, and we agreed on the scope of this project. This is a project that is being implemented in some other parts of the country by global funds and by Presidential Malaria Initiative, Malaria Partners International. So we have quite a number of international organizations working in different parts of the country. And because we have to work with Presidential Malaria Initiative, we only follow them into areas where they are already working. In the northern part of the country, yes, we are in Kebbi State. In the southern part of the country, we are in Akwa Ibom. And in these two states, we have started training of the trainers. We have started working with all the stakeholders, and we are ready to now go into the communities. The government, based on our request, gave us the hard-to-reach areas. That was where we said Rotary will make its impact. So in Kebbi State, we have 6 local government areas. In Akwa Ibom State, we have 6 local government areas. In these 6 local government areas, we have also requested for the very hard-to-reach parts of the state, of the local government areas. And that is where Rotary will work. Because of the size of our country, we have trained what we call advocates at both the national, and then we are now training the advocates at the state level. At the end of the day, we'll have a lot of advocates who will assist the country committee in penetrating in the selected areas that have been given to us. Thank you.
Thank you so much. And like I mentioned before, our chairs from the Democratic Republic of Congo, Rotarian Gaston Lukusa, and Gisela Betancourt-Mersal from Mozambique could not join us today. But in DRC, our Rotary members are collaborating with their implementing partner, World Vision DRC, and they're implementing in Kasai Province and aim to train upwards of 2,000 community health workers across 14 health zones. And in Mozambique, Rotary members are collaborating with World Vision Mozambique and are implementing in Manica and Tet Province, and they aim to train over 160 community health agents, 120 elementary community health agents, and 4,300 community health volunteers in Mozambique. All right, so turning back to our chairs who are with us today, let's talk about the model of RHCC. This is a new experience for Rotary members in convening a country committee led by Rotarian leaders, NGOs, ministries of health. Can you talk about how this model has worked for your country? I'll go with you first. PDG Larry, you touched a little bit on this. Can you expand on the model, how you were chosen, and how it's been working for Zambia?
Thank you very much once more. Yes, the model is pretty unique in the sense that although the leadership is in the hands of Rotary, we have many partners that had to be on board. And it obviously had to take reaching out to the various stakeholders so that they could recommend names of people that would sit on this country committee. And of course, it was very clear that we needed people that have time. I mean, this program is quite involving. It's huge. If you talk about training 2,086 people in different areas that are so scattered, it requires a lot of coordination. And apart from that, we also had to come up with subcommittees as well that would look at specific areas of the project. And one of these is the Finance Committee, which we charge with the responsibility of ensuring that expenditure is according to what is stated in the budget, and that the programs and processes involved in payments are above board. We also have the advocacy committee, obviously in charge with the fact that we have to reach out and sensitize people about the program that we're taking on. And this is a 3-year program, so it's not something that we could just think about doing in 2 weeks. It's a long haul. It required structures to be put in place. But one thing that's come out of this is that it's positioned Rotary directly in the face of the government. Because I think in the past, maybe they might have been seeing Rotary as an outsider, but currently, because of this coordination that we've had, they realize that actually Rotary is a true partner. And I must just say, it's not every day that you hear of the $5 million being pumped into a country, because that's a lot of money when you convert to local currency, and the impact that is going to have also is much more than that. So we now see that Rotary's name has been elevated. Recognition is given even in those remote areas where we don't even have presence of Rotary as well. So it's opened up many gates for us, many doors for us as well.
And for Nigeria, that shares the same model, but Nigeria being a lot larger with 6 districts. Dr. Dele, can you tell us about how this model with Rotarians as conveners and leaders has worked for Nigeria? And can you tell us just how many people are on the Nigeria Country Committee?
Thank you very much. The Nigeria Country Committee consists of leaders from each of the 6 districts. Each district contributed 5 Rotarians each. The district governor, the district governor-elect, the district governor nominee, then the district Rotary Foundation chair, and the district trainer in each of these 6 districts. Then we have nominations from the country committee chair, which I am, and then the different stakeholders were also asked to bring in nominations for the country committee. So PATH has 5 people in the country committee, and then we have some of our collaborators, like the Rotary Family Health Day. Yes, they have a nominee. The National Polio Plus has a nominee, and we also brought in some people from the government. So we have quite a large country committee. And from this country committee, we have the strategic committee, which has been put together to assist in the formulation of policies. We have the financial committee, which consists of people who are knowledgeable, accountants, bankers who are knowledgeable in financial matters. They have been handling the budget. We have the advocacy, and we also have the media committee. The media committee is responsible for all communications, both on the social and the traditional media, and they've also been responsible for planning, because media also involves a lot of planning with regards to external communication. That is with the country committee, the media committee, advocacy committee, strategic committee. Yes, that's the structure that we have in Nigeria.
Thank you. And both of you touched on advocacy, and we know advocacy is a very important action, is a very important thing as we go about implementing these programs. We've been collaborating with ALMA. We've had a representative here from ALMA in the previous session to help train Rotary members in the use of scorecards. In addition to other activities that the committees have planned, each country committee has an advocacy subcommittee. So starting with Zambia, can you tell us a little bit about what advocacy efforts the committee has led or supported, and what has made them truly effective?
It's just maybe to give a bit of the background on the areas that have been chosen for implementation of the project in Zambia. They are mainly in rural areas. So it's not the areas where you find, let's say, the town clerk or district secretary or mayor. So one of the most important things that had to be done was to realize that the community is not just a beneficiary in this project, but they're actually very important stakeholders. And the leaders in those communities are mainly chiefs or headmen. So the first step was to ensure that these are brought on board, because there are people that are respected in those areas. I mean, you cannot just go into a village without paying homage to the chief for a start. And once we got the chiefs on board, we knew that then the program had received blessings from the top person in that area. And it then became easier for us to ensure that the community is supporting the program and obviously offering the people from their own community for that training. We have also another level that this morning I think was referred to by past director Patrick Chisanga, which is the Malaria Council in Zambia, of which he is board chairperson. But we also have two other Rotarians who are members of that. We've got Martha and Lucy. I think you saw a photo, we saw in the video that was showing not too long ago. And the advocacy committee was very, very present and alive during the World Malaria Day. They participated, which was one of the areas in which we're implementing the project to ensure that they're seen there to be participating. And we were very intentional in choosing the chairperson for this particular committee. We appointed a former Minister of Health, who was also a retired general, because obviously he commands a lot of respect in the Ministry of Health, which is our very close partner. And we took advantage also of the visit of the RIPE. You heard today, it was mentioned this morning, when Mario was visiting Zambia. That was a very big thing. You know, he had other commitments, other projects that he was supposed to visit, but we ensured that he visited this, which is the biggest project being done in the country. Publicity was very high on the agenda, knowing, of course, you know, the high office that, you know, he was holding at the time. And we had the turnout of Rotarians on that day was very high. Normally, very few people would go there, maybe 3 or 4. But on that particular day, we had a whole group of Rotarians driving all the way from the city of Lusaka into the area where the project is being implemented. And high on the agenda, and the whole day was just this particular project. As you heard this morning, he actually participated in the testing. He was tested for malaria, and handing over bicycles, which were given to those cohorts that had finished their training at that stage. In addition to that, we recently had our district conference, which was held at the end of last month. We also took advantage of that and ensured that the works of the RHCC was highlighted as one of the major things that we had to see. So we had a panel of discussants. Eric, Martha, and Crispin did the job for us. That was a platform in which about 300 Rotarians from the whole district were present. So it helped us to reach as far as possible in terms of clubs and Rotarians, and even those family members that were present on that occasion. The other aspect in terms of advocacy which was done was that we took advantage of the training of the president-elect, incoming presidents, for those who are not Rotarians, who had their training in March. We dedicated a day and a half towards training of this particular project, making sure that we made people aware, sensitization, and also even covered the aspect of the AUMA scorecard. So presidents-elect were able to go through this process. They know what that instrument is for, to help us track where we're going in terms of malaria elimination. So those are some of the steps that we took. And because of the fact that we looked at the events where people were most present, our reach went much further, and they went back to their clubs to share what they had learned from the presentations that were made.
Thank you. And Dr. Balogun, advocacy is it's a big feat in Nigeria, given your population size and your great relationship with the government. Can you tell us a little bit about how the community has led or supported advocacy efforts?
Thank you, Dr. Nyreese Castro. Advocacy in Nigeria was handled both at the national and currently at the state level, and will continue into the local government level. At the national level, we took representatives from the 6 districts who were nominated by the district governor, and we also brought in other volunteers who are Rotarians. Altogether, we trained 60 people, 50 of them Rotarians, 5 from PATH, and 5 from the ministries. We trained them for 3 days, during which the scope of this project was clearly explained. To Rotarians, this is the first time we're having this kind of project in Nigeria, because it's a bit different from the program of scale. And we had to explain and explain and explain to the Rotarians what this program is all about, so that they can return to their respective districts as advocates and then explain to Rotarians, and the Rotarians at the district level can now go to their clubs and explain to the Rotarians what the project is all about. At the state level, it was a bit different. We paid visits to the Ministry of Health, to the State Primary Health Care Board, to the Ministry of Information, to the National Orientation Agency, to the Ministry of Youth, to the Ministry of Education, and we explained clearly how these different ministries, including Ministry of Women Affairs, will be involved in the execution of this project. We also paid a visit to the State House of Assembly, because they are particularly very, very important in creating enabling laws that will allow continuity and sustainability of this project. And we also paid a visit to the Nasara Foundation, which is a foundation that is being championed by the wife of the state governor, so that we can have a very good hold on the government, especially at the level of, we've not been able to meet the governor yet, but we have met his wife. That is in Kebbi State. Kebbi State is particularly unique. It's is the state in the north that has the worst data with regards to malaria and with regards to mortality due to malaria. Is a rice-producing state. Is a state that can produce enough rice to cover the whole of Nigeria and for export. So malaria is a very big problem in Kebbi State. But the Kebbi State is unique. There is no Rotary presence at all. It's a state with a population of 8.65 million people, no Rotary clubs, no Rotarian lives there, no Rotary club, no Interact club. So we started by establishing a Rotary club, and the Rotary club is still at the most elementary phase. The other state where we are in is the Akwa Ibom state, which is in the southern part of Nigeria, and is very rich with Rotarians and Rotary clubs, and it's easier for us there in Akwa Ibom state, I must say so. The current state governor is a Rotarian. The Commissioner for Health is a Rotarian. So it's a different scenario entirely, and the Rotarians there are very, very keen on the project, and we're working with the Ministry of Health, Ministry of Information, Ministry of Women Affairs to establish a proper understanding, and we started with the training of trainers, and we will eventually get into the community. That is the situation as far as advocacy is concerned in both Akwa Ibom and in Kebbi State. Thank you.
Thank you. So we hear about mobilizing Rotary members, mobilizing the community, and even the governor's wife. Someone mentioned earlier, women are getting things done, so that may be a great avenue of advocacy. Moving on to implementation, and I'll ask both of you to share a little bit about the progress to date. Like we mentioned, the programs are both about 9 months in. Where are we in terms of training? And any other key takeaways you'd like to share here?
Yeah, just similar to the program in Nigeria, the one in Zambia is also getting into the 9th month. There's a lot of learning that we're still doing, all of us as people who are involved in the project. But so far, we are on track in terms of the work plan. As at the end of last week, we're talking about having trained about 600 community health workers at various stages. Some of them have already been deployed in their community and they're doing the work, and others are still doing the phases of attachment in the health centers. So it's really work in progress. But I also just want to mention something perhaps that sometimes we tend to overlook about the people that we train to undertake. Because I mean, the whole day we've been hearing about being trained to track malaria, pneumonia, and diarrhea. But we also have to realize that because they are catching these diseases early and in their very community, the clinics are being decongested, health facilities. So people do not have to go into big numbers to attend the clinic. And because of that, the health facilities and the people that are working there have more time to look at patients who are presenting other kinds of illnesses. And when I looked at the bicycle there as well, I thought, yeah, but we think about a bicycle as something that is used by the person that we train maybe to go and reach a family that's outlying. But in a lot of cases, the people that we train are not just looking after those 3 diseases, because they know the community very well, and the community trusts them because they're part of them. That there are cases that are not related to those 3, which they can pick as they go because they've been given these ideas. And in some cases, the very bicycle that we see looking so simple becomes the ambulance that takes a person to be taken to the nearest clinic or health facility, which in some cases can be quite far. So it's things that look quite simple, but the impact that they have is a lot bigger, depending on where you find these people. And because obviously the first areas we're tackling here are those hard-to-reach areas or underserved areas as well. So we are providing a means of improving health in general and not just the 3 diseases that I thought we should realize.
Thank you, and that's very impressive. And we know that in places like Zambia, some of the data collection systems had to be upgraded in terms of we're now actively tracking diarrhea, we're now actively tracking pneumonia that previously haven't been done. So continue to talk about integration and delivering the full package. And as Pastor Governor here mentioned, even going beyond delivering that full package in many different communities, because that's the healthcare provider that they do have in their community. And Dr. Dele, similarly, where are we in terms of training and any other key progress notes you want to mention about Nigeria?
In Nigeria, thank you, Dr. Castro. In Nigeria, the government has a new policy on primary health care, and the new policy is much broader than what it was when they used community health extension workers. Now we have community health influencers and promoters, and they cover a much wider spectrum. It's still the same idea of going from house to house by trained people who have been selected by the different communities. But this time the scope is much wider than malaria, diarrhea, and pneumonia. It includes malnutrition and some other common diseases in these hard-to-reach areas. So we are retraining all the community extension workers that were used before. And these community extension workers were actually taken back to their communities to confirm that they are still living within those communities, and they are not just people who have been brought by politicians. They have been trained and retrained, and our implementing partner, PATH, along with Rotary leaders, have been involved in the training of trainers and the training of chiefs. We have not gotten to the extent of deploying them to the communities yet, because the program has to be launched at the state and at the local government levels. And we also have plans for social mobilization in each of the communities where we are working, and we are going to ensure, like in Kebbi State, we are working only in 6 local governments. They all don't speak the same language. We are using the National Orientation Agency to ensure that there's translation in the local languages in those selected areas. It is very, very important that we have community buy-in so that they can own the projects. And because we are thinking of community ownership, we believe very strongly that advocacy must get to the grassroots, and advocacy must continue all through this project and even after this project, so that the project can be sustained. We believe very strongly that for us to get the buy-in of the community, we must ensure that they believe in what we are doing. Thank you.
And thank you so much. And I want to thank my panelists here. And I'd like to wrap up by, saying a few words. A shift. We're seeing a shift in Rotary's strategy as we continue to approach many challenges in the global health space and global health infrastructure. Previously, or traditionally, we've made extraordinary efforts to provide direct service opportunities. We've directly provided medical equipment. We've provided commodities. We're out there volunteering, but we're really seeing a shift in strengthening health systems and building partnerships and really elevating those local leadership. One of the messages I want everyone to go home with today is integration, integration, integration. The Rotary Healthy Communities Challenge is just a flagship example of what we can do with the transition to mobilizing resources that wouldn't have otherwise gone to malaria, that is now being dedicated to providing integrated services. We moved on from providing charity to really having shared leadership, shared service with our country leaders, fully supporting our theory of change, so that Rotary members can use their experience and their expertise to really serve as conveners and decision makers. And we know that this style works because we've seen the successes of Partners for Malaria-Free Zambia, and we can continue this and really show that building upon our legacy with polio eradication and see how far we've come with polio and our work towards that, we can really build this structure, we can build this model that can not only be applied to these 3 disease burdens, but can be applied to any region of the world, can be applied to any disease burden by really strengthening community health workers. When Rotarians show up, Rotarians are leading, Rotarians are living in these communities, so they're there to stay, and we can sustainably strengthen health systems and improve health for children under 5. And I know I mentioned earlier, and I'm probably at the 1-minute mark of my remarks, but just saying, how can we stay engaged? How can Rotary clubs and districts who are both in implementing countries and non-implementing countries really be involved? If you're in country, join your country committee, show up to the meetings, show up to the trainings. Our studies and our evaluations show that just by Rotarians being there, community health workers are feeling motivated. And if you're not in implementing countries, partner with those RHCC countries. There's many gaps that exist due to the fallout of government, U.S. government resources. You still have access to global grants. You still have access to those resources. We can work together to fill those gaps. We can host awareness campaigns, celebrate World Malaria Day with us, and really partner on a global grant. Like I'm really stressing that because this is resources that all Rotarians have access to, and if we join forces, we can go even farther. And we really want Rotary to be not only seen for what we can give and what we can fundraise for, but how we can really lead in our communities across the world. So thank you so much.